Well, I think we can get started. Obviously, people will trickle in a little bit. I am still Emily Weiler from the Montana Public Health Training Center as of yesterday. We are excited to have you back. Thank you for returning to us. Very excited to see what Xana and Ethan have for us today. Just like yesterday, me and Amy are here. We'll be monitoring the chat box. So if you have questions or any tech difficulties, just let us know. And with that, I will turn it over to our lovely trainers again.
All right, thanks, Emily. Yeah, thanks everyone for joining again today. Yesterday was a lot of numbers, as we were just talking about, a lot of basic terms in epidemiology and some concepts. So today's going to be a little less heavy on the calculations and study designs and that kind of thing. And we want to go through some more applied type epidemiological concepts and specifically related to COVID. We're just going to go through a lot of different scenarios because epidemiology is not all numbers, but it's also thinking critically about scenarios and applying kind of science and epidemiology to situations particularly related to COVID. So that's what we want to walk through with you today. So we want to talk through starting out with just some mechanisms of infectious disease transmission, some steps we can take to assess and minimize our risk of COVID as we continue to navigate future waves of the virus. So maybe one of your questions coming into this is, is this pandemic ever going to be over? Is it over right now? We're seeing cases go down. Is it ever going to end? Those kinds of things. So the short answer is almost certainly a no. This is not over. We're very likely to see future waves of COVID and other variants pass through Montana and the United States and just globally. So what we're focusing on today is what the science says about COVID-19, what we've learned over the past 2 years, and some very objective measures that we can take to really minimize our risk during future waves that will almost certainly happen. So unfortunately, a little bit of depressing way to start out, just saying, no, this is not over. But on a good note, we've learned a lot in the last 2 years, and that's what we're going to kind of walk through today. So let's talk about preventing COVID and specifically in infectious disease epidemiology. We're just going to start with some important factors in this type of epi. So starting out with some terminology here, you might see a triangle like this looking at agent host environment. And these are 3 important terms in infectious disease epi. So an agent is what's actually causing the disease. So a virus or a bacteria, in our case, we're focusing on COVID-19. This is the agent. A host is an organism that's susceptible to the disease or us. The important characteristic about COVID-19 and us being the host is that COVID-19 had never before circulated in the human population. So we were all vulnerable to or susceptible to the disease. So we were all potential hosts when this started. And then environmental factors really impact, have a large impact on the infectiousness and how quickly a virus can spread. Also thinking through person, place, and time. And I think Xana kind of introduced this concept yesterday. So who's impacted by the disease? What do the people have in common? So this applied to early on in COVID-19 and the pandemic when we were trying to figure out what in the world was going on. Is this a new virus? Do we know anything about it? Person, place, and time, and just trying to pinpoint what's going on and where does this start? What are some characteristics of the disease? These are important factors. So some other characteristics just about different agent, host, and environment factors that can apply to different scenarios as well, because this isn't just about infectious disease epi. The agents can actually be chemicals or physical nutritional type agents. I've mentioned a couple of times yesterday that I study air pollution, and smoke and air pollution particles are chemical agents that can impact our health. And then these also give us some characteristics to look through and think through when we're discussing what host and environmental factors maybe put us more at risk for infection or adverse health outcomes, depending on what the agent is. And we talk a lot about risk factors for COVID-19. So these are going to be the host characteristics. So what age, sex, race, what characteristics like this, pre-existing conditions might put us more at risk for adverse health outcomes related to COVID-19. And then environmental factors are actually what we're going to spend a lot of time on today, talking about on ways that we can improve our environment, improve ventilation and things like that, what masks we can wear that will improve our odds or reduce our odds of contracting COVID. So these all play into infectious disease, epi in particular, but really any kind of epidemiology, these are all important concepts. A couple other concepts specific to infectious disease epidemiology are endemic, epidemic, and pandemic terms. So let's just clarify what these mean and where we're at. So endemic it's really the normal amount of disease in a population. This is what you would expect kind of year in and year out. It's not always ideal. If you think of malaria in Africa or Latin America, thousands of people a year are contracting and dying from malaria. It's certainly not ideal, but it's endemic, it's expected, and it's pretty predictable year in and year out. Whereas an epidemic then is an increase beyond that endemic amount in the population. So it can be a little bit subjective to define what exactly is an epidemic, but it could also be called just an outbreak or a cluster. It's kind of one of those things where when you see an increase in cases, you kind of know it when you see it. So seasonal flu epidemics, usually the flu is kind of minimal throughout the year. And then we get these seasonal flu epidemics in the wintertime. They're fairly predictable, but we don't exactly know what strain is going to be coming through. And so these are kind of considered epidemics within our country. And then a pandemic beyond that is something that's global. It's spread across multiple countries and continents. And I can recall a couple of years ago when they officially declared COVID-19 a pandemic. And at this point, now 2 years later, we've kind of come full circle, where I think some people are now considering COVID-19 almost an endemic virus, where there are going to be expected cases and it's not really going anywhere. And there are going to be waves that pass through and epidemics, almost like seasonal flu. I think this is almost what we could expect for COVID-19 going forward. So this is not what we'd hoped initially, but we've learned enough about COVID-19 that there are things we can do to minimize the impact of future waves and help decrease how those affect our communities. All right, two other important concepts in infectious disease epi are the mechanisms of infection. So there are two main types of mechanisms of infection: direct and indirect infection. So direct is kind of easier to understand and identify. It's really person-to-person contact. It's when you shake hands, when you hug, sexual contact, coughing or sneezing, and you expel these big droplets. This is direct contact, and that's, I think, what we think of when we consider disease transmission is this type of direct contact. But indirect contact is actually very common, and we're learning more and more that this is probably the primary way that COVID-19 is actually spread, is through indirect contact, specifically through airborne or aerosol transmission. So I'm going to spend quite a bit of time talking about aerosol transmission, what that means, and what we can do about that. But other ways of indirect contact are through objects that you touch, or fomites is what they're called in some circumstances, such as door handles, handrails, just public places where you touch something, you don't even think about it, and then you touch your mouth or something like that, or you go to eat and you've transmitted that virus through this indirect contact. I also mentioned, or I'm not sure if I mentioned, vector-borne contact. It is through vectors like fleas, ticks, or mosquitoes. So it's not a direct contact of that, or the agent is contracted to you pass on to you through these vectors, these insects, things like malaria or tick-borne diseases like spotted fever. These are vector-borne diseases, and also it's considered indirect contact. But today we're going to primarily focus on distinguishing droplet transmission, or more direct contact of COVID, and then indirect contact through airborne aerosol transmission. So these are important concepts in COVID-19. And what I'd like to do is just start off by kind of showing a video that talks about aerosol transmission and in the ways that COVID spreads and what we can do to minimize this. So.
Let's talk about transmission of respiratory infectious diseases. Respiratory infections are transmitted between two people when one is infectious and the other susceptible to infection.
When the infected person talks or coughs, they release a mist of particles made out of respiratory fluid that contains the virus. They can throw between 900 and 300,000 liquid particles from their mouth. These particles are less than 1 micron up to hundreds of micron in size. By comparison, the thickness of a human hair is about 100 microns.
One way to get infected is by contact transmission. When you touch a surface that has been contaminated by a virus and then touch your eyes or nose, you can get infected. There is not much evidence at all that this is the way you can get COVID-19.
The second way is when a spray of large particles, like a drop of rain, fly out of the infected person's mouth and land on your eyes, nose, or mouth. To get infected by this route, you must be close up to a person.
The third way you can get infected is by inhaling virus-containing particles that are floating in the air. This transmission route is called airborne or aerosol transmission. Some people think of an aerosol spray can of deodorant when they hear the word aerosol, but really an aerosol is just a bunch of particles suspended in the air.
Getting infected this way could happen by either being close up to a person, called short-range aerosol transmission, or when you're far away from a person, called long-range aerosol transmission. Animal studies, air sampling, and super spreading show that SARS-CoV-2 is transmitted by breathing in aerosols.
SARS-CoV-2 is an overdispersed pathogen like SARS and measles. This means as few as 10% of people transmit 80% of the infections, and many people barely transmit. Most infections happen within households, where 1 or 2 other people may be infected within your own bubble. Also unique to SARS-CoV-2 is that many transmissions are pre-symptomatic or asymptomatic, so you literally have no idea who is infectious. People are most infectious right before they have symptoms of the disease.
To prevent infections, we must control both short-range and long-range airborne transmission. Short-range is when you happen to be in close contact. If you are as close as 8 inches, you can get infected by a spray of large particles landing on your face. Between 8 inches and 6 feet, you will inhale the virus.
Long-range aerosol transmission also happens. This is how superspreading occurs, when you have a series of unfortunate events that happen all at once. A highly infectious person is indoors for a long time, shedding lots of virus, and there are also many susceptible people in the same space. The airborne virus begins to spread through the indoor space and builds up to high levels because there is poor ventilation, minimal surface deposition, and no air cleaning.
Why is this important? Because the way to minimize the risk is with different strategies. You will never prevent short-range aerosol transmission by improving your ventilation. The only way to prevent it is by wearing a good-fitting mask, staying socially distanced from the person, and quarantining upon possible exposure. And definitely when you start to show symptoms. The closer you are to somebody, the more virus you will encounter, so try to stay at least 6 feet apart.
To minimize the risk of long-range aerosol transmission and superspreading, we must treat this with ventilation and air cleaning, and still wear masks to reduce the amount of virus that you breathe in or that you may release. Reduce the number of people indoors so that the chance that somebody is infected goes down.
You cannot ventilate your way out of short-range transmission scenario, but you must ventilate your way out of a long-range aerosol transmission situation. And always use multiple strategies in case if one fails.
All right, I'm sure you've seen some videos like this before and you're familiar with some of these concepts. I think it's important to note a couple of things. The first of all is this aerosol transmission that we're going to talk a lot about today and ways to minimize. And I really like what they said in this video about we can't just do one thing and expect to reduce our risk. It's about multiple different strategies and in weighing in pros and cons in different scenarios. So that's a lot of what I want to talk through again today. I have another website here where it kind of walks through what some scenarios on being indoors and highlights a couple of other key points about aerosol transmission. So I'd like to just kind of move down to here. So it really, I think, helps highlight what aerosols look like. These are small particles. They remain suspended in the air, whereas the droplets fall to the ground in seconds. And so we can be infected through both aerosols and droplets, but aerosols with poor ventilation. So if you're indoors and the air is not circulating properly, they build up and become increasingly concentrated over time. But they're so small, they're invisible, that we don't know this is happening. It's not like smoke building up that we can actually visualize. But knowing that this is going on potentially in the background when we're in these situations where there are other infected individuals, I think it's just helpful to see these visualizations of how aerosols build up in concentration over time. And then also keeping in mind that the aerosol concentrations depend on the activities that we're doing in these situations. So if we're silent, we're expelling a lot fewer viral particles. So if we're just kind of hanging out in a group or in a classroom and there's minimal speaking going on, we're emitting fewer viral particles. So over time, the concentration stays lower. But if we're talking, the concentration builds up. If we're singing, shouting, or exercising, we're expelling more and more particles. And over an hour, the likelihood of receiving an infectious dose of the virus through aerosols goes way up. So it depends on, each scenario is unique. It's a little bit different. And it's just important to be able to kind of visualize what is going on with these aerosols and how they build up in concentration over time. So that's a really important aspect of COVID transmission. So we're going to come back to that, but so to kind of move on here, I just want to walk through these different steps of how do we kind of identify an outbreak, and then what do we do about that going forward. So the first step is identifying the infectious agent, and we've kind of talked about that a little bit of what are the characteristics of the agent. Early on in COVID, we really didn't know what was going on. We saw people getting sick and we had not identified what it was. So early on, it was just scrambling to see what is this? Is it a bacteria, a virus? Is it something we've seen before? Or is this novel? So early on, it was just about coming up with a case definition and some clinical signs where we could identify cases and try to put a stop to this. But it became very evident that this was a virus that nobody was immune to. And so it then went on to looking at other characteristics and using some epidemiologic tools to identify who's at risk. So a few things we kind of talked about a couple of these yesterday, but a couple other terms we can look at early on in an outbreak like this. One is an incubation period. So this is the time between exposure to the disease or virus and then the onset of symptoms. So early on for COVID, the median incubation was around 4 to 5 days, but it could be as high as 14 days from one case to the next, or from exposure to onset of symptoms. So that's why initially we had people quarantining after exposure for 14 days. This has changed a little bit with other variants. Some spread more quickly and might have a shorter incubation period. So this is a good a good concept to keep in mind as new waves spread through, we can kind of get an idea of what the incubation period is and how long we should be quarantining for. Incidence we talked about a lot yesterday, but it's not just looking at overall incidence of the virus, it's looking in subgroups of the population. So we can identify who's more at risk. Are there age groups that are more at risk? Are different socio-demographic characteristics, do they put you more at risk? Are pregnant women more at risk? Are elderly? Are those with pre-existing, comorbidities? Are they more at risk for contracting the virus or worse cases of the disease? So it's important to look at incidence among these different subgroups. Another way we can kind of look at this is a number called the attack rate among the exposed. And so this is where you take the number of exposed cases divided by the total number of exposed individuals. And this can be kind of difficult to do because we really need a closed population. We need to know how many people in a certain instance were actually exposed. So what we did early on is there were outbreaks on cruise ships. And so you kind of have a finite number with a closed population where you knew how many people were exposed on a cruise ship. And then you could say from that number, this many people became cases. And that gives you an idea in that closed population of how many individuals would contract the virus and really how infectious it is and how quickly it spreads. So looking at different scenarios like that are helpful. We also talked yesterday about using simple epidemic curves, and looking at the progression of the disease over time can be very helpful. But to do that, we really had to be able to identify cases. And that's why it was so important that we started developing tests early on for COVID. And then once we have the available information, calculating reproduction numbers, like we also mentioned yesterday, can be really helpful in learning about how the disease, how quickly the transmission is occurring. So, I've kind of mentioned this already, but early on, we had no idea what was going on with COVID. So we had all of these questions we were trying to answer. And that's why it took so long to develop tests to try to learn more about the disease. Who becomes infected? Can we be reinfected? How sick do people get? Can you spread it when you're asymptomatic? And how does it spread exactly? Airborne or droplets? We had all these questions at first that we were trying to answer. And now looking back 2 years later, we can finally, answer some of these questions and really come up with ways to put ourselves at lower risk during the next wave. So, once we've kind of learned this basic information, this initial information, the next big step is to identify cases of individuals. So testing. It's a very important concept in COVID. So we want to be able to track an ongoing outbreak. We just need to be able to identify cases. If we want even something as simple as an epidemic curve or any of these calculations, they all hinge on identifying cases. So luckily, by the time COVID got to Montana, we had already developed some tests, and we had these PCR tests, and they've improved and we've become more available, and we've developed rapid tests in the meantime. So testing has improved, but it is still not perfect. So a couple important aspects about testing are related to false negatives and false positives. So these two terms are sensitivity and specificity. All right, now sensitivity is the proportion of patients with a disease who tested positive. So higher sensitivity equals fewer false negatives. And specificity is kind of the opposite. So higher specificity equals fewer false positives. This can be difficult to keep track of. So let me pull up another website here. This can be a really helpful activity, I think. So again, it's a good link to keep in mind. This will be included in the slides when you get these, but in this scenario, we're looking at 100 people who tested for COVID-19. So we're starting out with a test sensitivity of 70%, a test specificity of 95%. So it's a very specific test, similar to like what our PCR test would be. but it's a little less sensitive. Okay, so you test 100 people, and what does this look like? So in this figure then, it kind of divides people up on if they're true positive, true negative, false positive, or false negative. Now, since our sensitivity is only around 70%, we have quite a few false negatives. So we have quite a few people in this lower left-hand box here. But if we raise that sensitivity up to 95%, rerun this, you can see we have a lot fewer false negatives. Those individuals were bumped up into the true positives because the test was more sensitive. So you can play around with these numbers. Say we lower the specificity to 70%. That's going to bump some of these true negatives into the false positive. Since we have lower specificity, we're going to have more false positive tests. So in an ideal world, we're going to have perfect sensitivity and specificity, but that just doesn't happen. And we'll kind of walk through why that is. So today we're going to talk about the PCR tests and the antigen tests, but just know that they're not perfect and that there are going to be some false negatives and some false positives. And based on how good these tests are, you can kind of play out some scenarios using this, this online tool here. All right, so we're going to talk about a couple different types of tests. You know, these have evolved some over the course of the pandemic. They will continue to evolve. So this is really just meant to be an overview and talk through some of the strengths and weaknesses. But starting with the PCR tests, these were the first tests that were developed. They're, I think, still regarded as the most accurate test. But RT-PCR stands for reverse transcriptase polymerase chain reaction. You might hear these called molecular tests or nucleic acid amplification tests. If you see NAAT, that's the nucleic acid amplification test. So these are diagnostic tests. They will only diagnose active infection, not past infection. You know, they're typically taken, as we're probably well aware by now, from nasal or throat swabs. And the turnaround time is highly dependent on really the testing capacity. The turnaround time can be a day or less if there's adequate testing supplies and personnel to run those tests. However, if not, if we're in the middle of an outbreak, the turnaround time could be days potentially, just depending on that availability. Right, so when we talk about sensitivity and specificity, these tests have very few false positives, so they're highly specific. Essentially, if you test positive using a PCR test, you can be very certain that you are actually positive. But they have the sensitivity then varies, and that's where it depends on when you were tested during the course of your illness. So the best time to test is shortly after symptom onset. And this figure kind of explains why this is. So this is looking at the likelihood of testing positive based on when you were exposed and when you became symptomatic. So if you truly have COVID and you were exposed, you were less likely to test positive early on after you were exposed. You are most likely to test positive right around the time you become symptomatic. So that's kind of the sweet spot. If you think you were exposed, you think you have COVID, you want to test around the time you were symptomatic. And that gives these tests the highest likelihood of detecting a positive test. So this is where false negatives come into play on these tests. If you test too early on in your infection, you might get a false negative. If you test too late in your infection, you might get a false negative. So that's why these tests are not perfect. Some of it depends on timing, and some of it just depends on how infectious and how much virus you have in your system. So they're great tests, especially few false positive, but just understand that the timing of the test can impact the false negatives. So antigen tests are fairly similar. These are rapid diagnostic tests. Again, they're diagnosing active infection, not past infection. a faster turnaround time than the PCR tests in general. And, you know, these are becoming more and more widespread, more available. And so I think more people are relying on the rapid antigen tests compared to the PCR tests. Antigen tests are also highly specific. They have relatively few false positives. So if you test positive, you likely are positive, but they're less sensitive than the PCR test. So if you test negative, it could be a false negative. And they're not perfect in this regard for similar reasons that the PCR tests were not perfect. So that's why they recommend typically serial testing for these rapid tests. So you might wait a little bit after, wait a few days after you're potentially exposed, test, and if you're negative, you test again the next day or something like that to verify. If you're symptomatic and you have strong COVID symptoms, even if you test negative, they might recommend something like a PCR test or serial testing with the antigen test to double check, because they do sometimes have false negatives. So keep that in mind. And finally, the antibody tests. In contrast to the previous two, antibody tests are looking for past infection, not active infection. So these are the blood tests you would get. I've got an antibody test at health screenings at work, and they can have a pretty quick turnaround time, but they're looking for past infection. So a couple of caveats with this is that antibodies can take time to appear in our system. So if you're tested right after you're infected, you might show up as a negative. So it could be a false negative depending on when you're tested. They could also potentially detect antibodies from other types of coronaviruses. So false positives are potential with antibody tests as well. Generally, we don't rely on antibody tests to say if we have immunity to COVID-19. The best way to know if you have immunity is if you've previously confirmed a PCR test that you were positive for COVID-19, or if you're vaccinated. Antibodies are really most helpful for a population level to say how many people in this population have likely had COVID-19 previously and have some immunity. At an individual level, they have some unreliability. So there are a number of different testing strategies that we've tried out throughout the pandemic, including, most of our testing has been symptomatic testing, just because we're oftentimes during an outbreak, we're overwhelmed, and the testing strategy it's just important to do symptomatic testing and focus on isolating and identifying individuals with active COVID-19 infection. And unfortunately, because of that, asymptomatic type testing has kind of taken a back seat. So early testing, could miss some cases, and asymptomatic testing can be helpful in places, if you think you've been exposed and you want to quarantine and prevent others from getting tested, or if you work in a workplace that's higher priority, where, if you're working in some public infrastructure place, you can't have an outbreak in this type of workplace, then asymptomatic testing might be more important for a setting like that. But typically we have focused on symptomatic testing throughout the pandemic, just because availability of personnel and tests to run these tests, as well as contact tracing, which we can talk about briefly here. The problem and the tricky thing about COVID-19 testing is that the symptoms are so generic. And I think we're probably well aware of this by now, that the symptoms overlap with things like allergies, with colds and flu. And so what do we do? Do we just get tested every time we feel a sniffle coming on? That's why it's been so tricky to know who to test, when to test, and how often to test in our population, because these symptoms are so generic. There are a few things like the loss of taste and smell that are seemingly pretty specific to COVID-19. So we look out for those, and we look out for the most common types of symptoms like headache. But that is one of the aspects that has made this so difficult on really focusing in who to test. Contact tracing, we won't talk a whole lot about, and some of you are likely trained contact tracers and already know about this, but if not, there are resources out there if you want to learn more about contact tracing. again, it is helpful in stopping the spread. If we have the infrastructure and the personnel to do contact tracing, in an ideal world, we would contact everyone who is potentially exposed and give them recommendations on quarantining to stop further spread. But we do not live in an ideal world. And when there are waves of COVID, it can become almost impossible to do contact tracing. So we had to prioritize testing and other resources for that reason. All right, so for the next few minutes, I want to get a little bit more into, just what aspects of our environment can we do to help, assess our risk and minimize our risk during COVID-19. And a lot of this has come from the scientific studies and research, epidemiologic and scientific research. So this is kind of the state of the science, what we know about COVID, what we've learned over the last 2 years, and how we can go about minimizing our risk, really at individual levels and at community levels as well. So social distancing, early on, this was a big part of, in our tool belt of how we thought we could reduce risk of COVID, of contracting and passing on COVID, was just standing 6 feet apart. And I think people latch onto this and it became a little bit oversimplified. The point was, we want to reduce our contacts, we want to prevent the spread of droplet transmission. So if we're standing 6 feet apart, we're less likely to spray people in the face while we're talking and transmit those droplets. So that's great, but we've also learned that COVID spreads through aerosols. And it's not just those droplets. So it's the smaller aerosols that stay floating in the air that are one of the primary methods of transmission. So the 6-foot rule is not really as simple as it sounds then. It's still helpful to do this in some scenarios, but this alone will not stop the spread of COVID. Other things we can do to prevent aerosols is what we're going to talk about on that. To prevent the spread through aerosols is what we'll talk about on the next few slides. But reducing the amount of exposure by the time we spend indoors with people, increasing ventilation and using and properly wearing masks. So these are some of the best things we can do. So again, just another figure, just kind of trying to drive home this concept of droplets versus aerosols. We're really concerned with COVID and about these smaller droplets that stay suspended in the air. Social distancing will help reduce our contact with these larger droplets, but it's the medium and smaller size droplets that we're really concerned with. So social gatherings is one important aspect of our environment, and that we really need to think critically about our interactions with other people. Right now, COVID is going down across the country, and there are certain times like right now where we had to think less about this, but when we're in areas of high community transmission and struggling to contain the virus, when healthcare is becoming overwhelmed, then we really need to think about social gatherings and what aspects of our gatherings with other people that we can really focus on to reduce risk.
Hey, Ethan.
Yeah.
I'm gonna interrupt you for a second. There's a comment in the chat from Amy about PCR testing.
Yeah.
So Amy, if you want to ask your question or give your comments.
Yeah, hey guys. Can you hear me all right?
Yes.
Yep.
Yeah. Okay. Sorry about that. I was hanging out listening with my office mate. We're trying to get our volume good. So sorry it took me so long to be able to log in and jump on, but I just wanted to bring up that you mentioned that PCR testing can only detect an active infection. And that was what we had presumed. That's kind of how we've operated with PCR testing in public health for quite some time. And I just wanted to share that what we found was that PCR will actually pick up an infection up to 3 months old. And so that made our jobs like super interesting, like in all of these surges, to figure out who actually was currently infected and who probably had it 2 months ago and then ended up being tested just because they were a close contact or whatnot. So I just wanted to share that, like that was our understanding, sorry, of PCR testing before COVID. And then that's kind of what we found out after was really, we had to sort through who was an active infection, who had a likely exposure, did they have symptoms? And then of those, it was always fun to try and pick out the asymptomatic people and be like, you just have it. We don't know when you had it, but we're going to act like it's now. So I just wanted to share that because I don't know that that's widely known and understood, that the PCR will pick up that viral shedding for quite a few months after. So I didn't want to contradict what you said, but I thought it's a really fascinating thing that was a development that we all learned, you know, throughout this pandemic. So sorry to butt in, but I just wanted to share that.
Yeah, no, thanks for chiming in. Yeah, and that certainly complicates things too. I think most people, when they're going out to get a PCR test, they typically are actively experiencing symptoms. So that scenario you describe, it doesn't apply to everyone, and it's the people who are actively experiencing those symptoms that are getting the PCR, but it certainly complicates how you interpret tests, and it adds another layer of just how complicated it is to identify cases and really put a stop to this. There's another comment I see about antigen tests. Thank you, Brandy. Just kind of clarifying the difference between how the tests actually work. Antigen tests are detecting antigens, and then the PCR tests are detecting presence of the DNA from the current or prior virus. So yeah, that helps clarify a little bit. All right. So let's talk about social gatherings and kind of some scenarios where we can think through how to assess and minimize our risk. In all along, we want to kind of think about multiple things that we can do, because we're not just talking about social distancing. We're wanting to think through multiple different kind of interventions and practices that we can do in public settings, so that in future waves of COVID, kind of how can we arm ourselves to really assess different risk in different scenarios and reduce our risk, but still go about living our lives. You know, I think it's a balance there. So there are some good resources on the CDC. It's always good to keep an eye on your community transmission levels, and that will really help you weigh what are the current risks. So, you know, bookmark your favorite COVID websites, whether it's the CDC, your local county website, or the state of Montana. Some of those resources we shared yesterday, but keep following up on those and stay up to date on the current conditions. And then, you know, when it comes to social gatherings, it's good to consider things like indoor versus outdoor, because when we're talking about the virus spreading through aerosols, outdoor gatherings reduce our transmission substantially. Outdoor, there's good ventilation, even if there's no wind outside. There's unlimited space for aerosols to kind of spread out and disperse. Whereas when we're in an indoor setting, there's limited area and concentrations will gradually build up. But in an outdoor setting, the virus and these aerosols that the viruses are transmitted on will continue to disperse because there's unlimited space for them to do so. And if you're out in a breeze and there's a breeze outside, or if you're out walking, like this is even more beneficial. So outdoor gatherings are one of the best things that we can do, aside from things like vaccinations and masks. Just spend time with people outdoors. But we also realize that we can't always do that. Wintertime in Montana, it seems like it lasts half the year, and we can't always have picnics. So public versus private gatherings are important. If you know who's in the party, if you know the individuals you're with, then you have a better idea of what their risk level is and how much they're exposed to. And that gives you just a better sense of the risk of spending time with these individuals. Versus when you're in a public setting, you have no idea who you're with generally. And it becomes very difficult to assess risk. You have no idea if someone who is there has recently been exposed, or if they're asymptomatic or starting to feel symptoms, but still at this gathering. Same concept goes for large versus small gatherings. And then at-risk populations is another important concept we want to really hamper on today, because individuals with pre-existing conditions, older and younger individuals, or particularly older individuals, these are the most at-risk populations. And I mean, you might think that you're fine, you're young and healthy, but if we're at gatherings with at-risk populations, we know that COVID can be spread in asymptomatic individuals. And at-risk populations, whether you're immunocompromised, have pre-existing conditions, this needs to be a serious consideration in who you're spending time with, if you're an at-risk individual, and who you are spending your time with, and in what settings. Because we know that most of the serious illness and most of the deaths from COVID come in people who were previously at risk with other comorbidities or immunocompromised populations. So a really important concept to just keep considering depending on your social situation. Now, I kind of talked about improving ventilation by spending time outdoors. That's a huge thing you can do. Gathering outdoors. If you can't do that though, if the weather's bad, if it's too hot or too cold, and you're indoors and you're gathering, just do things like open windows if you can. Run your HVAC system. Anything that's going to get to circulate the air in the indoor environment is going to move those aerosols and clear them out of the room, so that the concentration doesn't build up as much. So whether that's running the HVAC system, running fans or exhaust fans, using portable air cleaners is something I really advocate for, because us in Montana, we know that these also help during wildfire season. So if you can get your hands on a portable air cleaner and use that during social gatherings, it will not only help with COVID, but you can use that during wildfire season. If it's a high quality filter that uses something called a HEPA filter, this will filter out both wildfire smoke and viral particles. So I really advocate for these if you can afford one, if you can get your hands on one. Portable air cleaners are great. You know, they're used in clinics and dental practices, and you commonly see them in these types of areas near where patient populations are coming in and out, and people, you have to go to work, you have to be in these areas, but portable air cleaners improve our ventilation. Brand names of portable air cleaners, I use a Winix filter, a Winix brand at home, but I think in general, as long as it has a HEPA filter, so HEPA stands for high efficiency purified air, HEPA. If you see it has a HEPA filter, then I don't really care what brand it is. HEPA filters are like the N95s of filters. N95s are the best mask. HEPA filters are the best quality for filtering out particles. So if you see that any brand has a HEPA filter and a replacement filter isn't outrageous in price, then I would go with it. There are a lot of different brands available today for portable air cleaners. But yeah, if you want, I can also send some examples. So just look for ones that have replacement filters that aren't crazy expensive. That's a key point. So this kind of demonstrates visually some good versus poor ventilation. In the top figure, the windows are closed. They're not running the HVAC, no portable air cleaner or fans or anything. So the aerosols just stay suspended. They have nowhere to go. But when you have good ventilation, the fans are going, the windows open, you're running a HEPA filter. Yeah, the ceiling fan is going, this is clearing out the aerosols, and within an hour they're gone. And this is just a demonstration in a photograph here or in a picture here, but I think this gives a great representation of how well ventilation actually does work. And there's a CDC tool here actually that gives an interactive tool. If you want to go to this website, you can kind of put in some criteria based on your household or where you're going to be. You can change the HVAC operation, the type of setting, if you have a portable HEPA air cleaner, if you're opening windows, and just walk through different scenarios and kind of look at the particle reduction in your home using these different practices. So ventilation is key. I will keep talking about that, but that one's a great tool to keep using. So what about when you're traveling or flying? Really, all of these previous concepts apply. If you're traveling by car, you can fairly easily socially distance. You can stay in places where you're comfortable, where you can socially distance. You can go out to eat if you're comfortable with that. You can check the CDC website to see where community transmission is at in each destination you're going to, and really judge separately at each destination what your risk would be, and use all these practices, doing things outdoors if you can. I really think traveling by car, it can be relatively safe. And even during times where there's higher transmission, if you know how to weigh your risk and things you can do to minimize that. If you had to fly, that's a completely different scenario because it's impossible to socially distance in airports and on planes. So the best thing you can do when you're flying is to wear a quality mask. In general, I would avoid flying if the transmission is at the highest level. It's just hard to avoid each scenario when transmission is high like that. It's hard to really minimize your risks very much. But the best thing you can do when flying is wear a quality mask like an N95. So we're going to kind of talk about masks now, the effectiveness of different masks, what you can do, how you can wear them. Masks work in general, but some are far better than others. And if you use any mask, use them consistently. Wear them over your face and your nose and mouth. Any mask is better than no mask. But what we need to consider why N95s are the best masks is what we know about aerosols and how these are microscopic particles that are staying suspended in the air. Because I think when people think of masks, they think, well, as long as I'm blocking my mouth and nose, I'm probably fine. But that's just not the case. If we're wanting to block aerosols, we have to basically use that mask as a filter. And so we have to have a good seal on our face. And if there are any creases, or if there are any parts along our cheek or along our chin here where it's not sealed against our face, we will be breathing particles around that unsealed area and into our lungs. So the point of a quality mask is that it fits well around your nose and face, and that is what N95s are made to do. Cloth masks and surgical masks just do not do this as well. The other point of a quality mask like an N95 is that it is actively filtering out particles. I have a link to a video. We might not have time to watch it today, but they're actively filtering out particles because using electrostatic filtration. Cloth masks do not do this as well. Surgical masks are a little bit better, but N95, that's why they're the best, is because they seal around your face and they're built specifically to filter out particles. So when we look at this, cloth masks at the bottom here, they're fine. They're better than nothing. If you wear a cloth mask, wear it over your mouth and nose, try to get a good seal and wear it consistently. It's better than nothing. A little bit better than that is a surgical mask. Surgical masks do filter out particles a little bit better, but they also do not seal around your face the best. The next step up then is a KN95 or double masking, which will filter a little bit better and also seal around your face a little better. And then N95s are considered the best just because what I said, they're built to fit around your face well and filter out particles. Now the technology with an N95 and a KN95 is actually very similar. So they will filter out a similar amount of particles, but N95s are built to, the straps will go around your head, not just around your ears, and they're specifically made to filter out and to fit to your face better so that they filter out more particles and you're getting less leakage around the mask. So I also realize that this is it's difficult to find N95 sometimes, and particularly early on in the pandemic. We were saying leave these for the healthcare personnel, but now things like KN95s and N95s are widespread. So if you can get your hands on these, it's great. This is what you should be wearing. If you can afford a quality mask, if you can find one, then I would recommend wearing these, during the waves of COVID. Yeah, I think Emily, that's great for speaking of the different filters, and we can also send recommendations for masks that we could wear. So yeah, it's if you can find it. If you cannot find or you can't afford a KN95 or an N95, then another alternative would be to double mask. And an important thing to note about double masking is that it's made to look like this: a surgical mask on the bottom, and then a cloth mask on the top. So the point of this is that the surgical mask is the better mask, but it doesn't seal to your face the best. So putting a cloth mask over the top helps push it down and seal around your face better, improving the actual filtration. So what not to do is this: you should not double mask with a cloth mask and a KN95. I don't know who this is. I just found a picture on Google, but this is what not to do. This person is wearing a cloth mask and then they have like a KN95 over the top. That cloth mask is actually doing more harm than good. It's creating a worse seal for the KN95. So if you have a KN95 or N95, just wear that and make sure it fits around your face well. Don't double up with cloth masks with KN95s or N95s. You should just be doing this scenario here. That will get the best seal and the best filtration for masks. And there is a lot of science behind masks as well. Compared to not wearing masks, the cloth masks lower your odds of testing positive, surgical masks even more so, and then the respirators like N95, KN95 are the best. So yeah, if you need references on where to go to find these, on what to look for in a mask, just reach out to us. But hopefully this kind of hits home the importance of wearing a quality mask. I also want to just continue to point out that this is all, the effectiveness of masks and all of these practices just depends on the scenario. So this kind of walks through some different steps. That there's an asymptomatic carrier here and an uninfected person. If they're close together, there's a good chance that uninfected person could get sick. If the uninfected person is wearing a mask, they might still get sick unless that mask is something like an N95, because that infected carrier is going to be spreading those aerosols in close quarters to that uninfected person. If they're blocking some of those aerosols, then that is helpful. If they're both wearing masks, then that's great. But again, unless those are the best masks like N95, there's still a possibility of transmission. If you're wearing masks and distancing, then that lowers it even more. So it's all about the situational aspects of where you're at and what you can do in each situation to reduce your risk. So, we hear often in public health practice about different recommendations that we can do. But I think we often latch on to things like the 6-foot rule and staying social distancing, or just throwing on any kind of mask, that this is going to help, and it certainly won't hurt. But we have to really diagnose each and dissect each different situation to understand what our risk is. And I'm hoping that by going through some of these examples that maybe you're better equipped to assess your risk in various scenarios. So as we kind of get close in on 3 o'clock here, we're going to start to talk about herd immunity, and then we'll take a break, and then Xana's going to talk to you about vaccines and some medical treatments for COVID. So quickly, just talking about herd immunity, I think it's a concept we've likely become more familiar with, but essentially we're just talking about enough of a population becoming immune to the disease that it makes spread less likely. So it's an important concept, but it's always not as simple as it might seem, because herd immunity can change. We've also learned that people can get reinfected with COVID, whether you have had previous infection from COVID, you have natural immunity, or you've been vaccinated, or both. It is possible to get reinfected. So that kind of changes the way we look at herd immunity, because we know we can become reinfected. And the problem with that is, I think we shoot for the single value, like we have to reach 75% vaccination rate, and then this is just going to go away. But that's not the case. It's an oversimplified kind of explanation that we're going to get to this herd immunity level and that everything's going to be fine. Again, we're trying to minimize our risk as a community, and natural infection and vaccination will reduce that risk. But I think now we're at the point where this just isn't going to go away. So the more people who are vaccinated, the more people who are immune, the better in general, but also keeping in mind that we can become reinfected. And this is probably here to stay. Early on, there was this debate on natural infection to herd immunity. Do we just let everybody get it? Do we just have no restrictions on public health, let everybody get it, become immune, and then it's going to go away? And I think we learned pretty quickly that this is not an ideal scenario. There were circumstances where we were overwhelming the healthcare system, and hundreds of thousands of people in our country died. And I think without public health interventions, it would have been even worse than this. And we also, I think, are still not understanding what the long-term consequences of having COVID are, what long COVID looks like. Are there long-term health outcomes related to having COVID infection? So there are a lot of different aspects that make natural infection to herd immunity unrealistic. So we're going to talk about the benefit of vaccines. Xana's going to kind of walk through with you how vaccines are developed, how they work, especially these new mRNA vaccines, and then how effective they are in preventing COVID and preventing severe COVID particularly. So it's 3:02. Why don't we take a 10-minute break, and then Xana is going to come back and talk about vaccines with us. And so let's come back at 3:12 or so. And also happy to answer any questions if anybody has any at the moment. So thanks.
Thanks, Ethan.
Is usually a very lengthy process, taking on average 8 years to get approved. Since a few years, we have the ability to create mRNA vaccines, which can be developed much faster. So how do these vaccines work? Are they safe, and how do they compare to traditional ones? But first you must understand how the immune system works. When a virus enters your body, it will attach itself to one of your cells and inject its DNA or RNA into it. This is like a blueprint for your cells, containing instructions on what the cell has to make. So in this case, the virus's RNA will tell your cell to make more copies of the same virus. They become factories, assembling new copies of the virus that can infect even more cells. But don't worry, our bodies have a defense system for foreign intruders. The immune system attacks any protein, virus, or bacteria that does not belong in our bodies, but it takes a few days for it to learn how to attack the intruder. Meanwhile, the virus factories are running non-stop, quickly replicating the virus and spreading it in your body. In other words, you start experiencing symptoms of whatever has infected you. After a few days, however, your immune system will have figured out how to attack the virus and will start producing antibodies. These attach themselves to the virus, preventing them from infecting more cells and marking them for destruction. As you can see, the immune system is remarkable, but it's slow to mount an attack. That is the reason why we can get sick in the first place. So to give it a helping hand, we developed vaccines. The main idea is to train your immune system to recognize and fight off an infection before it has occurred. Almost like showing your immune system a mugshot of the virus and saying, if you see this, kill it. There are various types of vaccines, but let's take a look at the new kid on the block, mRNA vaccines. To understand how they work, let's take the COVID-19 pandemic as an example. You might have seen pictures of the virus with its distinctive spikes. These spikes allow the virus to attach to specific cells in your body and infect them. Now, here's the key idea for the COVID-19 vaccine. What if we could train our immune system to recognize these spikes by having our own bodies produce them? To do that, researchers took the virus's blueprint, its RNA, and isolated the part responsible for producing the spikes. Armed with this blueprint, they created mRNA, or messenger RNA. This is a special form of RNA that can enter your cells and give them instructions. In this case, the RNA contains instructions to build the spikes of the coronavirus. Not the virus itself, just the spikes. So mRNA vaccines contain instructions for your cells that tell them to build a part of a virus in large volumes, almost like giving them a recipe to follow. Once this is happening, your immune system kicks into action and starts learning how to attack these intruders. Again, it takes some time for the immune system to fight off these spikes, but you won't get sick because it's only the spikes, not the virus itself. And that's it. Your immune system has learned how to attack the spikes of the coronavirus. It destroys all the spikes and even breaks down the mRNA vaccine itself. The only thing left in your body are special B cells or memory cells. These can linger around for months or years until the same virus infects you again. When that happens, the B cells can produce the correct antibodies right away, preventing the virus from spreading and making you sick. What's interesting about this mRNA technique is that it's relatively quick to develop a vaccine as soon as we know the DNA or RNA sequence of a virus. And secondly, because the vaccine only makes our bodies produce a tiny part of a virus, we cannot get sick from it. More traditional vaccines use weakened versions of the actual virus. This also triggers an immune response, but could also give you mild symptoms. Now you know how mRNA vaccines work, but don't take my word for it. All sources used to make this video are listed in the description below. Check it out.
Cool, so that was just kind of a brief introduction summarizing vaccines to get us started. I want to run through some of the same concepts that they talked through. Give me 1 minute to share my slides here. Okay, so we're going to spend the next 15 or so minutes talking a little bit more about vaccines. And so like this video talked through, the whole purpose of vaccines is to train your body how to build up an immune response. There are different types of vaccines, and they talked through this a little bit. The mRNA vaccine, so that's the Pfizer and Moderna. There are other types of vaccines like the weakened or inactivated virus, and the chickenpox or polio vaccines would be examples of those. So after our bodies learn to recognize some part of the virus or the bacteria from the vaccine, we then produce an immune response as if we were infected. But since we're not really infected, we don't get sick, but our bodies will remember this response in the future if we are exposed. So just to go through some of the different types of vaccines that have been mentioned. So mRNA is the one that we're going to spend the most time talking about today. And that's again, the Pfizer and the Moderna vaccine. And so if we look at on this chart, that would fall into the RNA-based vaccines. And so you can see that there are all sorts of different kinds of vaccines. These inactivated are the ones that I mentioned around like chickenpox and polio, where you actually have a piece of the virus that's been inactivated or weakened. Now, the Johnson & Johnson vaccine is the other COVID-19 vaccine, and that's a non-replicating viral vector, so it would fall into this category. And the way that this works is the response from your body is the same, and so your body is still learning how to produce the spike. But instead of getting the mRNA through like the Moderna and Pfizer, what Johnson & Johnson does is that there is another harmless virus that carries that same code to make the spike. And so that's how it gets into your cells, is through this non-replicating harmless virus that's not SARS-CoV-2, but it delivers that same spike protein. So just to walk through another visual of the mRNA vaccine and kind of the response that your body is having. So again, what we're really aiming to do is train our body to recognize that spike protein that's found on the SARS-CoV-2 virus. So once we had the virus sequenced, we were able to start producing the vaccine. So they produce the mRNA portion of it. And the way that it kind of enters the body is that the rest of the vaccine is made up of kind of like fat droplets. That's how it gets transferred into your cell. The mRNA enters your cell. What it's doing is it's carrying the mRNA to create a protein, the spike protein. So it goes to find a ribosome, which is the part of your cell that makes that protein. So it goes to find a ribosome. It tells your cell to make the spike protein. Here we are in figure 4, having made the protein. Our body starts to recognize that as an intruder. It starts producing antibodies, and we get that immune response that we're aiming for. A couple of things to note that have kind of been maybe misinformation out there. The mRNA enters your cell, finds the ribosome, and then it's degraded by your body. So it never enters the nucleus of your cell, and it doesn't alter your DNA. So actually, when they were first developing these mRNA vaccines, one of the problems they had was that they would enter the body and it would degrade too quickly that it couldn't find a ribosome. And so eventually they discovered that these fat droplets are what would keep it alive long enough to enter your cells. So your body does degrade it. It doesn't stick around, and it doesn't alter the DNA in any way. So the length of time that our bodies kind of remember that immune response varies based on the virus or the bacteria that it's protecting against. And this is why you need boosters for some vaccines and not others, or different schedules for certain vaccines. For the Pfizer and the Moderna vaccines, the study showed that 2 initial doses were needed to achieve that full immune response. And then as studies were ongoing and more people were vaccinated, the immune response was starting to decline after 5 to 6 months, and that's when they started recommending a booster. So thinking just generally about how vaccines are developed, they go through these 5 different stages. So just kind of from a big picture view, there's the initial development, then they go through a series of clinical trials. Once we have results from those clinical trials, they go through authorization or approval through the FDA. We then start manufacturing and distributing those. And then as the vaccine is distributed and given to people, there's ongoing monitoring. So if we think about these 5 different steps as they relate to the mRNA vaccines for COVID-19, for the initial development, we already had the mRNA technology. We just needed that spike sequence identified in order to start producing the vaccine in a laboratory. For the clinical trials, all 3 phases for the COVID-19 trials occurred, but they overlapped. Just to give you a sense of what this looked like, phase 1 of the clinical trials typically has around 200 to 100 people. For the Pfizer clinical trial, phase 1, they had 45 participants. And then for Pfizer in phase 3, they had about 44,000 participants. So after we get those results, experts review the data from those clinical trials for authorization. Typically at that point is when it gets manufactured and distributed. For COVID-19, the process overlapped, and manufacturing and distribution actually started before they were approved, just to make this process go quicker. And then monitoring is still ongoing for these COVID-19 vaccines. So just looking at that timeline, kind of this top image shows what the traditional development looks like. So it's 1 step at a time, where with the COVID-19 vaccine, all the steps were still done, but some of them overlapped. And that's why this happened so quickly. So just running through kind of the process that we might ask ourselves, how do we know it's safe? How do we know it's effective? So for the vaccine, if we want to know how is it safe, kind of the first thing to think about is that all phases of the vaccine development were followed. And in some of those initial clinical trials, there was an extremely low percentage of adverse events. So just to give you an example of this, we can't run through all of the data from each of the vaccines, but for Pfizer and that phase 3 trial, which had about 44,000 participants, it was a randomized control trial. And so half of the participants got the vaccine, half of them got a placebo. And when they compared the percentage of adverse effects between the two groups, it was 0.6 for the vaccine, 0.5 for the placebo. So notice in this data that one, it was an extremely low percentage of adverse events, and it was similar between the two groups. So that's kind of the evidence that's showing us that it's safe. And then there's ongoing reporting kind of above and beyond the initial clinical trials. Again, confirming the same low percentage of adverse events. So allergic reaction is one of the adverse events that's being tracked. And in terms of confirmed cases of allergic reaction, just to give you some context, there were 21 confirmed cases out of 1.9 million doses of Pfizer, 10 cases out of 4 million doses of Moderna. So again, really low percentage of these adverse events being shown in this ongoing monitoring. One other kind of adverse event or side effect that's been kind of popping up in some studies is myocarditis. And they did a descriptive study looking at 192 million individuals that have received an mRNA vaccine. And they found 1,626 verified diagnoses of these myocarditis. So again, really low percentage of adverse events. But ongoing studies, and I just included kind of a description of what this study looked like. It was a descriptive study, and they found that it was more common in young men, but again, still very low percentage of these adverse events. When we look at 1,600 out of 192 million, we're really talking about a very small percentage. Now, another question to ask ourselves is how effective are the vaccines? And so there are two ways to look at effectiveness. The first is during the clinical trial period, we want to know, as we're studying, before we're approving this vaccine, how effective is it? And then we can also look at effectiveness ongoing as we continue monitoring those who have gotten the vaccine. So starting first, looking at kind of the clinical trial information, again, sticking with the Pfizer, although there's similar information for the Moderna vaccine as well. The same phase 3 trial that I've mentioned a couple times with 44,000 participants, randomized control trial, so 22,000 received the vaccine, 22,000 received the placebo. In total, during the phase 3 trial, there were 170 cases of COVID-19 for the entire 44,000 in the 2 months. And then we looked to see how many of those cases were in each of the groups. So 162 out of the 170 cases were in the placebo group. 8 out of the 170 were in the vaccine group. So 95% of the cases were in the placebo group, 5% in the vaccine group. So if you hear the terminology that it was 95% effective, that's what it's referring to, is that 95% of the cases were in the placebo group. So good evidence that it's effective in the clinical trials. Again, this study was a randomized control trial, which is our gold standard. So just another thing to think about as you're looking at, some of these clinical trials for maybe the Moderna vaccine or Johnson & Johnson, just thinking about what kind of study was done. And like we talked about yesterday, randomized control trial is our gold standard. So thinking less about the trials and more about ongoing monitoring, we can continue to look and see what the effectiveness is of those who are vaccinated. So I pulled some data here from the CDC, and what it's looking at is both the number of COVID cases, and then the next slide we'll look at is the deaths, and it's broken down by those who are vaccinated, those who are fully vaccinated and those who are unvaccinated. So the chart that we're looking at here is the number of cases. And if we remember from yesterday, if we look on this axis, it's the incidence per 100,000. So if we look at the incidence of cases, the dark line here is for the unvaccinated, the light blue is for fully vaccinated. And we can see this gap here where those who are unvaccinated are more likely to get COVID-19 compared to those who are fully vaccinated. We see a similar but more pronounced trend when we look at the deaths. So this would be the incidence of death per 100,000. And we can see a larger gap here between those who are unvaccinated versus those who are fully vaccinated. So visually, that's kind of what the chart is telling us. And then the CDC down here at the bottom has calculated a couple of other data points to help us understand what our risk is. So those who are unvaccinated as an adult, this first box here, 2.4 times higher risk of testing positive for COVID-19 and 14 times higher risk of dying from COVID-19. So with this ongoing data, we're seeing that vaccines are effective both for preventing cases and or lowering your risk from getting COVID-19 and to a larger extent, lowering your risk from dying from COVID-19. So similar type chart, but this time it's looking at hospitalizations. And so in this case, unfortunately, the colors have swapped here. So the light blue is the unvaccinated and the green is fully vaccinated. And we can see that this green chart, this green line across time has remained relatively stable. It did go up briefly, but it still is showing this large gap between those who are fully vaccinated and those who are unvaccinated, that those who are unvaccinated are much more likely to be hospitalized compared to those who are fully vaccinated. And we can break this down just a little bit further to look at those who are unvaccinated, those who are fully vaccinated, and those who are fully vaccinated with a booster. And we can see that there's still a gap between all three of these groups. So those who are unvaccinated are still the most likely to be hospitalized. This dark blue here is those who are fully vaccinated but don't have a booster. And then light blue here are fully vaccinated with a booster. So showing again that the booster here is providing more protection against hospitalization than simply having the first initial 2 doses. So all of those charts kind of put into words from the CDC. So again, ongoing data has told us that, for hospitalizations, it's 7 times higher in unvaccinated adults that you would be hospitalized compared to those who are fully vaccinated. So just different ways to present the information. But again, ongoing monitoring is showing that these vaccines are effective against your risk of getting COVID-19, dying from COVID-19, and being hospitalized. So I want to switch briefly to talk about medical treatments. We're not going to be able to cover all of the medical treatments, and this information is changing as we're doing more studies and gaining more evidence around what's working and what's not working. In general, there has been a lot of controversy surrounding the effectiveness of different COVID-19 treatments. Some have been shown to be effective while others have not. And just something to keep in mind, and why we went through those study designs yesterday, is that it's really hard to fully understand cause and effect and discover the true effectiveness of a treatment. Studies are hard to perform. We often need multiple studies in multiple populations to all agree to give us strong evidence to really say that one treatment is effective. So research studies for these different medical treatments is ongoing, and the FDA has approved some treatments for emergency use. The recommendations are always changing and ongoing research is underway. So when you get these slides, I've included a link here just so you can see, this is a place to come look for the updated information because a month or 2 months from now, information that I would put on a slide would be outdated as we learn more from more studies. Before we kind of get into a few examples, just want to mention again that the most important role of public health is preventing COVID-19. And so that's why we spent the majority of today talking about prevention strategies. But just to kind of weave in the information we talked through yesterday about study design into how you might think through evidence for medical treatments as things are changing over the next few months to years. So these medical treatments, they undergo a similar research and approval process that we talked through with vaccines. And so just to give you an example of one, remdesivir is FDA approved for certain patients. And there were 3 primary studies that helped the FDA determine its emergency use. I just pulled out one of those studies for us to look at. So one of these studies, it was a randomized controlled trial. It had about 1,000 participants. And so about half received a placebo and the other half received the drug. And so what they did was they compared recovery days. And so those who received the drug recovered within 10 days on average versus those who received the placebo recovered in 15 days. And so that's what this chart is showing down here. This is on clinicaltrials.gov where they're reporting their results. They're showing some information about their placebo group. They're showing some information about their kind of trial group. And we can see what the exact sample size was for each group. And then this is where they're reporting, the 10 days for the experimental group and 15 days for the placebo group. So there were 2 other studies that the FDA used with some similar evidence, but just showing you, what it would look like to log in and see what one of these studies is saying, and to help think through, what kind of study was it? It was a randomized controlled trial, which is our gold standard. What was the outcome that they were looking at? What's the difference between the 2 groups? That's kind of the process that you might go through when looking at a study. The one other medical treatment that I'll just touch on as an example is ivermectin. And I know somebody asked about this yesterday as well. Currently, ivermectin is not approved by the FDA to treat COVID-19. And the current data shows that it's not effective against COVID-19, and that taking large doses can be dangerous to humans or may lead to interference with other drugs. Many studies for ivermectin are still they're underway. And so I looked this morning at the clinical trials website, and there were about 85 different trials. You can scroll through them all and you'll see that some are, completed with results, and then others say they're not recruiting yet, or they're still recruiting. You can kind of see what the status is. I did want to run through just kind of a good example of, thinking through some of the study design and the topics of epidemiology that we've covered. Somebody asked yesterday about a meta-analysis specifically around ivermectin. There have been some meta-analyses done. Like I just mentioned, there are about 85 clinical studies on ivermectin and COVID-19. And throughout, I think about the last year and a half, there have been some published meta-analysis studies that kind of combine data from different studies to kind of see what the agreement is among those different studies. One of those meta-analyses was published back in July of 2021, and I have the link here if you want to check this out. And that meta-analysis back in July of 2021, their results showed that there was a 56% improvement in survival for those who took ivermectin for COVID-19. But since July of 2021, there has been some more information about the quality of the studies that this meta-analysis was based on, and they've reanalyzed the data and the results don't hold up. So actually they've retracted their initial meta-analysis and they've published an updated one that I want us to kind of look through some of the results on. Because the updated results show that there is no significant improvement from ivermectin. So just kind of harping on the point that the quality of your research studies matter, what the sample sizes matters, what type of study it is matters, whether or not there was bias, all of those different pieces we talked about yesterday really matters when trying to make, kind of that cause and effect to kind of come up with whether or not something has a cause and effect relationship. So just real quickly going through this meta-analysis, they started with, I think it's 12 studies, which they were using to come up with their results. And what they did when they redid their analysis is they grouped each study, whether it had a high risk of bias or a low risk of bias. And actually one of the studies also had fraud in it. So what they did is they said, well, let's throw out the fraud study and then let's see what our results would be if we did not include the studies that had a lot of bias in it. And what they found was the study with the fraud and the studies with high levels of bias were the ones that showed ivermectin was effective, where the studies with the low levels of bias were the ones that showed no effect. And so this is why it's really important to not just have a lot of studies, but to have high quality studies and for those to all be in agreement. And again, sample size is really important. So even once they pooled the sample size from all these different studies, we're still just looking at a sample size of about 2,600 versus, remember, in the phase 3 trial of the Pfizer vaccine, we were looking at 44,000. So a lot less confident in a sample size of only 2,600. So just another thing to keep in mind. So the new results from this meta-analysis showed kind of just different levels. So this red bar is showing, well, there was a significant result when we included all 12 studies. But if we drop down a bar, let's say we get rid of that fraudulent study because it was just bad information to start with, all of the rest of the results are now showing that there's no significant benefit from ivermectin. So when they got rid of the fraudulent study, there was no significant result. When we got rid of all of those high-risk studies, there was even less of a result. When we only used the best studies, there was even less of a benefit of ivermectin. So just one example of how the quality of study really matters. There have been some meta-analyses, but again, the quality of the underlying studies from within a meta-analysis also does really matter. So just my kind of takeaways from this, look to the FDA for the current guidance on approval. You could also check out clinicaltrials.gov if you want to see the individual studies and kind of assess those for yourself. You can search within clinical trials for COVID-19 and then any other drug like ivermectin, and it would pull up like that list of 85 that have been underway for ivermectin. Research is ongoing. Just keep in mind that the gold standard is the randomized control trial, and that the more consistent our results are across different studies, the more evidence we have that a treatment is effective. And with that, I'm going to pass it back over to Ethan.
Great, thanks a lot, Sana. Really important subjects that we've covered so far today. And I know there have been some controversial subjects too. You know, we have about 15 minutes left today, and I'd like to take the remaining time to just kind of walk through some scenarios and some examples of weighing and assessing risk factors and reducing risk. But any questions as we kind of come to the end here and talk through some examples? We want to make sure if there are lingering questions, we want to make sure we have time for that and we can get to your questions. And yeah, please speak up if you have those. All right, while you're thinking about that, let me pop the chat open here. Oh, thank you, Amy. All right, so in the last few minutes here, while you're thinking of questions or yeah, just kind of processing things, let's go through some information, just some scenarios on ways you can assess your risk. I'm gonna give you some tools here in the last few slides, and then we'll go through some scenarios. So the first thing is there are different sources for things like this. This is a good activity matrix. So we've talked through all these different scenarios and things you can do, whether it's considering gatherings, the activity that you're doing, if it's indoor or outdoor, what's the ventilation, are you wearing masks, are you vaccinated? There's just a lot of different considerations. for assessing your risk to COVID. And so there are a couple of different good resources like this where you can kind of go through this matrix. And this is really good for individual level risk assessment. You can go through these, and there are a couple of different similar examples. They just give you different scenarios where you can say, all right, I'm going to a social gathering. I want to kind of weigh my risk here and see what are things that I can do to lower my risk of COVID, particularly if we head into another wave and you want to just kind of have something to go to and try to think through the specific scenario that you're in. So do come back to these activity matrices like this. This is also not considering vaccination status. So if you're vaccinated, that's going to decrease your risk in a lot of different scenarios, but just know that it takes multiple different practices. Vaccinations are great and good masks are great. Ventilation is great, but doing one of those things is not as good as doing all those things together, as many things as you can given your scenario. There are also risk calculators out there. This is a pretty good link. It gets into some really in-depth questions about the scenario that you're in. So if you're, worried about doing something for the holidays or that type of thing, it can kind of walk you through different circumstances and scenarios and help you weigh your risk on this website. So that's a good resource. When we talk about community level risk, then kind of expanding beyond this individual level risk and looking at our communities, the CDC does have some good information on this, but there's this community level risk assessment that's a relatively new tool that they've put out. So there are these low, medium, and high values, and really this type of tool is dependent on, they want to look at the healthcare utilization in your area. So not only are they looking at cases in your area, but what impact are the cases in the current COVID level having on the healthcare system? Because the goal is with the tools that we have now, we have vaccines, we have tests and treatments. So the goal is really to make it feasible to be able to treat people as they get COVID and not overwhelm the healthcare system. I do think that in some circumstances, tools like this oversimplify, especially for individual level risk assessment. And at the community level, you're leaving it up to people on when they should wear a mask. So, there are pros and cons of tools like this, but there are good resources to look at a glance. And this one in particular is looking at healthcare utilization, which is an important factor going forward in COVID-19. We've also talked some about community level risk assessment, and this is looking at both cases and test positivity. So just another aspect, another way to look at this and assess community risk in your community. So we've got links for both of these tools. And we've repeatedly said that this transmission risk, from low to high is a good kind of tool to assess the community risk where you're at. So you can do this by county, and whether you're traveling or you're at home trying to assess risk in your workplace, this is a good tool to kind of refer to. One that I really appreciate goes into a lot more detail, and some public health professionals put together this community level risk assessment tool that incorporates a lot of different aspects that we've talked about. So we can kind of go through the community level transmission, and then this will give you kind of an indication of, based on whether you're in the red, orange, yellow, or blue, what can you do about masking indoors, about testing, about isolating, community level actions, and then examples almost on an individual level of things that are okay and not okay to do. And, this isn't cut and dry ever. There's a lot of overlap in these things, but this is a great tool to assess risk, I think, at a community and an individual level. So please refer back to this in the notes and resources that we give to you. And with that, yeah, I'm happy to answer questions, and we do have some scenarios to go through here. So I'm going to pop this first scenario up on the screen, and just when you look through these, I kind of mentioned this community transmission risk. So refer back to this, think back to this, whether we're in the blue, yellow, orange, or red, and then try to refer back to what all the things we've talked about, the mass and ways to minimize risk, and for each of these scenarios, what we could do and what your individual community level risk is and ways you can minimize that. So in the remaining time, it would be great if we could get some interaction here, if people would want to speak up a little bit and just kind of talk through these scenarios or throw some ideas out in the chat. Yeah, or else if you're a little uncomfortable doing that, please just think amongst yourselves on what you would do in this scenario and to minimize your risk. So I see a question from Will. We are constantly being asked if COVID vaccine will be an annual booster. Any insight? You know, I can't say for certain, but I would expect there to be more boosters, and I would expect that this could be something. Yeah, and Amy, if you want to chime in here, I would expect that this does turn into something we get boosted more regularly, and potentially as if there are new variants of concern that circulate, and maybe boosted or around those times. But Amy, what are you saying to individuals you talk to?
Yeah, so what, you know, our understanding right now is that because we haven't kind of ironed out, there's no seasonal COVID at this point. We just get wave after wave. So it's not predictable yet, like influenza is. So what I tell people essentially is, you know, without being able to say for certain, that I do believe we will eventually get on top of this and be able to predict it. You know, once we find out what settles in endemically, then we'll be able to have specific vaccines. And I always probably talk way too much to people when I'm on the phone, but I explain the reason why you get a flu shot every year is because they've figured out you're most likely to get the flu, you know, between October and March or April. And so you are protected if you get that flu vaccine in the beginning. And so I just explained the differences really between flu and COVID, and how flu was like this in the beginning too, you know, like way back when they first developed vaccines. So until we're at that point and we have more data and we're able to predict COVID, I just tell people that we recommend just getting boosters until we can settle into a more kind of seasonal COVID. But again, that's with the asterisk that we don't know right now. But I think that it is becoming more predictable. And the nice thing is that we get to see what's happening all around the world really before it hits us in little Mineral County. So we, you know, we have a really good heads up before things start really cooking. So I think we've got a good system moving forward. But that, I mean, that's not a short answer, but I definitely think it can be condensed into, at some point, yeah, I do think that we will be able to just give yearly boosters as opposed to just every 6 months, every 5 months, because I'm one of those people that I got vaccinated like at the absolute wrong time. So all of my boosters are going to end up hitting like when we're in a lull. And then when we have these big outbreaks, that's when I'm at the very end of mine. So I've even considered going a little bit longer and then trying to kind of do it more seasonally when people come indoors more, like all of the things that you guys talked about today. You know, in wintertime, we tend to go indoors a heck of a lot more with other people. So your exposures are much higher. So sorry, I'll get off my soapbox, but that's what we tell people.
Yeah, no, good thoughts. And Brian has a good comment in here too, that Pfizer is seeking approval for a combo COVID flu vaccine right now. So I think, you know, we're trying to get ahead of things a little bit on future waves of this, but yeah, it's not going anywhere, but I think we're learning how to maybe predict a little bit better, and you know, whether that's boosters or seasonal combo with a flu vaccine, we're trying to learn how to get ahead of this, and we're learning more and more each year and each time a wave comes through. So anybody want to talk through the scenario, or are there other questions that we want to go through too? All right, so if there are no other questions, let's look through this here for a minute here. So a community transmission in your community is in the red, so it's at the highest level. You invite a group of friends over, around 10 total, for dinner at your home during the holidays. There's a mix of vaccinated and unvaccinated individuals. So we want to kind of talk through what are the good things in this scenario, what are the not so good things, how can you, like, what practices can you do to reduce risk?
I would like to say that I wouldn't do this. Like, this seems like a bad idea.
But if you did this, there are a couple of good things. That it's a private gathering, so you are with a minimal number of people. It's a private gathering, so you likely know who you're working with here, and you know that some people are vaccinated. So there are a few good scenarios here, things in this scenario. But the bad thing is the community transmission in the red, so that increases the likelihood that somebody is showing up that is potentially a carrier of COVID. So here's kind of what I wrote for some notes on this one. Yeah, it's great that it's a private event. There's relatively few number of people. Some are vaccinated, but it's not so great that transmission is in the red and you're still doing this event. It's an indoor event, so you don't know how well the ventilation is going to be, and some people are still unvaccinated. So what I would recommend here is that best thing you can do, if you're meeting for dinner, you're likely not going to be wearing masks. Best thing you can do then is improve ventilation. If you have rapid tests, you could get tested before and after the gathering. If it's not terribly cold outside, you could spend time outdoors together and just do things like this to, yeah, you can wear masks and social distance when you're not eating and things like that. So there are practices, even in this scenario, when community transmission's in the red, there are ways that you can minimize your risk. So again, you know, we want to take what we've learned these last 2 years and put these things together and not just stop living our lives, but we want to know how to be safe while we are living our lives and use a combination of these different practices to minimize our risk. In just the last couple minutes, maybe we have time for one more of these, but community transmission is in the orange in this scenario. You attend an outdoor concert at a large venue. You are vaccinated, but only around 55% of the adults in your community are vaccinated. So what's some of the good and the bad? What would you do in this scenario? Yeah, Emily, it's great that it's outdoors. Yeah, that's going to help a huge amount. It's also great that you are vaccinated, and community transmission is not in the red. So these are somewhat ideal. Yeah, try to distance as much as you possibly can. So here are some notes that I made. The bad things about this is that this is a large public event, so you know nothing about the other individuals there. Some people are going to be unvaccinated because vaccination levels are relatively low in your community. So at a community level, this is a risky situation, but it's good that it's outdoors. One of the best things you could do is wear masks. If you're not eating or drinking, wear a good mask. You could do a rapid test before you gather if you want to protect others, after you gather if you want to just check on yourself, and socially distance if possible. Yeah, get tickets where you're not sitting right next to each other or crowding next to other people. I have several more of these. You're welcome to look through when we hand out these slides, but we're getting up on 4 o'clock here, so I also want to respect everyone's time and just give any last opportunities for questions as we finish up here. But yeah, thanks a lot. Hopefully this has been helpful, and it's kind of been a crash course in a lot of this stuff. Hopefully the focus on COVID has been helpful, and yeah, you've kind of left today with some tools that can help you going forward and navigating things here. So.
Yes, feel free to ask any remaining questions. I did put a link to our little evaluation survey in the chat, so if you can take a moment and fill that out, we really appreciate the feedback. It allows us to continue to offer trainings and make sure that you're getting what you want. So please fill that out for us. Thank you so much, Xana and Ethan. This was fantastic. I learned something new every time I hear you guys present, and I love that. Again, certainly the floor is open if anyone has any questions, and I will send out slides and resources and all of that shortly.